Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I am the Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's webinar, Calcium, a primer for healthcare professionals in partnership with the Dairy Farmers of Canada. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health, and in the risk reduction and treatment of osteoporosis. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism, and is a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises our board and staff on scientific and medical issues. OC provides medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars, podcasts, digital tools, and resources available at osteoporosis.ca. We are very excited about today's presentation, which will provide information about calcium, its bioavailability, and why it is essential for bone and overall good health. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. Without further ado, it's my pleasure to welcome our speaker today, Dr. Geneviève Mailhot. Geneviève is a registered dietitian, a full professor in the Department of Nutrition at the University of Montreal, and a researcher at the CHU Saint Justine Research Centre. She is also a member of our Scientific Advisory Council. Her research interests focus on vitamin D, cystic fibrosis comorbidities, particularly bone disease, diabetes and intestinal disease, and nutritional challenges in lung transplant candidates and recipients. Please join me in welcoming Geneviève.
So, good afternoon, everyone. I'm very pleased to be here from Montreal to talk about calcium. So, I will begin by just saying that I have no commercial affiliations or conflicts of interest regarding the content of this presentation. And as Kerry mentioned, I am a member of the Scientific Advisory Council of Osteoporosis Canada. So today I'm here to talk about calcium. So many things to say about this wonderful element. So I will talk about calcium sources and bioavailability. So I will really focus on bioavailability because I imagine that you probably know a lot about what are the various calcium sources. I will cover what factors affect calcium bioavailability, and then I will move to calcium recommendations because there are a lot of calcium recommendations. So I will try to make sense of all these recommendations, including the guidelines from Osteoporosis Canada. I will answer the question if here in Canada we are getting enough calcium. I will speak about sustainable healthy diets, and finally cover some frequently asked questions about calcium that maybe you've already heard of or you are asked in your everyday practice. So let's begin with bioavailability. So what is bioavailability? So it's really the way a nutrient, so it could, here it's calcium, of course, that interests us, but it's the way a nutrient is absorbed and used by the body. So for calcium, you know that calcium is important for bone health. I guess we all know this, but it's also important for various physiological functions. For instance, muscle contraction needs calcium, neurotransmission needs calcium. So these are vital functions that so that's why calcium is an essential nutrient, not only for bone health, but also for other vital functions. So there are many factors that would affect either absorption of calcium or the use of calcium by the body. You have endogenous factors, of course, the physiological status of an individual, so pregnancy, lactation, growth, aging, or menopause, vitamin D status, hormonal status, genetic background, GI health, and medical conditions could all affect the way we absorb calcium or use calcium in our body. So these are endogenous factors. But in my presentation, I will focus more on the exogenous factors, which are intrinsic to the food we eat. So it could be a chemical form of calcium. So for instance, we add calcium to a variety of foods. So foods are fortified with calcium, and we use different chemical forms of calcium that may have different bioavailability. There are other compounds in food that may affect calcium absorption, and the food matrix as well could affect the way we absorb calcium. What is consumed with the food that contains calcium? So for instance, proteins could affect calcium bioavailability. Iron could complex calcium in the GI tract and affect the amount that is absorbed. So this is what is consumed with food. And also there is the medication that people take. So for instance, proton pump inhibitors would affect gastric acidity. That would impact the way calcium is dissolved in the gastric juice, and later the way it is absorbed in the intestinal tract. So I will ask a lot of questions during my presentation, and I have a few also true and false statements. So this is the first one here. Calcium from plant-based foods is poorly absorbed. So we would think that this is true, but actually, sorry about that, actually it is false because calcium absorption varies by source. There are some plant-based foods that the calcium could be absorbed as well or even better than certain animal-based foods. So I will explain you why in the next slides. So here I show you a graph where I put on the y-axis the calcium content of several food sources, and on the x-axis the absorption rate of this calcium. And here you could see that spinach contains calcium, so a medium amount of calcium, but this calcium is absorbed only at 5%. Then you have legumes and almonds, which contain the relatively similar amounts of calcium as spinach, but this calcium is slightly better absorbed at 15 and 20% of absorption. Then you have this category here, so the animal products, dairy products, of course, and fishes with bones, because calcium is found, of course, in the bones of salmon and sardines. So these are considered sources of calcium, and this calcium is absorbed at a rate of 30 to 35%. In this category, you have mineral waters. I put it at the bottom of my graph because mineral waters or sparkling waters do contain calcium. It's naturally they naturally contain calcium, but in very, very low amount. However, this calcium is absorbed at a rate of 30 to 35%. Then you have the plant-based beverages, which are fortified with calcium. There is also the tofu and the orange juice, and this calcium is also absorbed at a rate of 30 to 35%. And the calcium supplements are also absorbed at the same rate. And lastly, you have all the greens vegetables, so broccoli, especially kale, bok choy, which contain very low amounts of calcium, but this calcium, surprisingly, is highly bioavailable. So it is absorbed at a rate of 50 to 60%. So why there are so much variation in calcium bioavailability? It's because the presence of several compounds in these foods. So for instance, in spinach, you have a lot of oxalate. So the blue bars here is the oxalate, and the red bar is the phytates content of these foods. So here it's for 100 grams of edible portion. So high oxalate content means that this oxalate would bind calcium in the GI tract, and calcium cannot be absorbed, so it is excreted in the stool. So this explains why the calcium from spinach is absorbed at 5%. Then you have all plant-based foods such as almonds and legumes, which have high phytate content, and for almonds, it also contains oxalate. So here, this could explain the presence of phytates, which is also which also binds calcium in the GI tract, but to a more moderate extent than oxalate. But the high phytate content of these food sources could explain the relatively low calcium bioavailability in these food sources. Then you have the greens. So the green vegetables do not contain oxalate or phytate. So this explains why the calcium, even in very low amount, is absorbed at high rates. You have the soy milk, which contains phytate, but still, because we add calcium to these plant-based beverages, calcium is bioavailable, similar to dairy products, and it's also the case for tofu because it's made of soybeans. So the phytate actually is present, comes from the soybeans. Here I just kind of look into the literature and found this very interesting paper because it's very new. Actually, it was published in 2025. Data from the US in US adults. So you probably know that in US they have these huge surveys, national health and nutrition examination surveys. So they survey what Americans eat. And in this paper, they analyze data from 1999 up to 2023. And they look at the phytate, oxalate, and calcium intake in US adults. And you could see here, and why we don't have Canadian data, so that's why I show you the US data, but probably it's similar here, the same situation here. You could see that over the years, our intake or the intake of phytate and oxalate in the US has increased, whereas the intake of calcium has shown more variation. So it peaked until 2012, but then decreased thereafter. So with time, it seems that we eat more phytate and we eat more oxalate, and unfortunately, calcium intake seems to be more on the decreasing trend. So they also look in this paper at calcium absorption, and you could see that because of the phytate and the oxalate intake that increased, but calcium absorption decreased. I just want to draw your attention that the y-axis is set at 24%, so it's not 0% here, but still over the time, calcium absorption decreased in the US population. And they also look at bone health outcomes, so the BMD of the femur and the femoral neck also showed a decreasing trends over the years, whereas the osteoporosis and fractures were more increasing with between 1999 and 2023. However, with fracture and osteoporosis, these outcomes were self-reported, so this is, of course, a limitation. Another factors that may affect calcium is the presence of dietary fibers. So, of course, the plant sources of calcium also contain fibers, and I just want to distinguish that there are two categories of fibers. So dietary fibers could be either soluble and or insoluble. So they both have this property of increasing stool mass. So they are good for this purpose, but otherwise they have different properties. So soluble fibers, they tend to form a gel-like substance in the GI tract because they kind of disperse in water. And moreover, they are fermented by our gut microbiota. So because of this fermentation, they produce metabolites that would help calcium absorption. So soluble fibers are actually good for calcium bioavailability because they enhance calcium absorption, especially in colon, which is not exactly the place where calcium is normally absorbed, but they have this capacity of promoting calcium absorption in a distal segment of the intestinal tract. Whereas for insoluble fibers, they do not disperse in water and they are poorly fermented by our gut microbes. And because of that, they have more an inhibitory effect on calcium absorption. They would tend to physically entrap calcium and kind of keep calcium, and then calcium would be excreted in the stool. So when we look at the sources of soluble fibers in our diet, is mostly fruits and vegetables, as well as certain grains and seeds. So these are not sources of calcium, but they, as I said, could help or promote calcium bioavailability from other food sources that are consumed with these sources of soluble fibers. Whereas for insoluble fibers, you could see here that the calcium sources I showed you at the beginning of my talk, they contain more insoluble fibers than soluble fibers, but it's not a major factor that would contribute to the lower calcium bioavailability in these foods. It's more the phytate and oxalate content, because you could see here that broccoli and bok choy, which are two sources with high calcium bioavailability, they're also rich in insoluble fibers, and fibers do not contribute to reduce calcium bioavailability in these sources. Regarding fortification of food with calcium, so here in Canada, there are many plant-based beverages that are fortified with calcium, especially calcium carbonate or tricalcium phosphate. So these are the chemical forms of calcium that are found in these food products. Whereas in orange juice, it's a different fortificant. So it could be calcium lactate, again, tricalcium phosphate, or calcium citrate malate. Why is it different? It's just a matter of solubility. Orange juice is more acidic. So because of this property, it would be more, it's better to use different fortificant to make sure that they are soluble in that food product. For tofu, we use calcium sulfate, calcium chloride, and there are some brands of cereal that would contain calcium carbonate. In general, these fortified food sources have a calcium bioavailability that is similar to that of cow's milk. So for soy milk, orange juice, tofu, we don't have any data for cereals, but we would expect that it's very similar to cow's milk as well. The only exception is soy milk fortified with 3 calcium phosphate. Data have shown that there is a 25% lower calcium absorption in these products. And also there is this sedimentation issues with soy milk, meaning that calcium is not always, it could be found at the bottom of the container of soy milk. So this could, of course, it could decrease the amount of calcium that is found in soy milk because it's at the bottom of the container. But we do not have a lot of data on other plant-based beverages. So for instance, here in Canada, we have oat milk, almond milk, cashew milk, even pea milk or coconut milk, but there are not a lot of data regarding calcium bioavailability in these specific products. So here I have a question. So regarding energy and sport drinks, are they fortified with calcium? So the answer is no. So, but I would say I should be more nuanced. It depends on the brands, but in general, these products are not fortified with calcium. Sport drinks such as Gatorade, for instance, contain other electrolytes, but not calcium. So electrolytes such as sodium, of course. Whereas energy drinks, which is the Red Bull, for instance, they do not, these drinks do not contain calcium. Nutritional drinks such as Boost and Ensure are fortified with calcium. Of course, they could be meal replacement options. So they contain as much calcium as a glass of milk in one serving of these nutritional drinks. Here, a true and false statement regarding milk and other animal proteins. Do they leach calcium from bones? Is it true or is it false? So it is false, and I will show you why. So this association or this link comes from the intake of sulfur-containing amino acids, actually. So proteins with high content of these amino acids. So these amino acids are methionine and cysteine, and those are found in animal source of proteins. And when the body actually metabolizes these amino acids, it produces an excess of protons. So protons are acid molecules that will decrease the pH and cause what we call a metabolic acidosis. Of course, the body doesn't like a decrease in its blood pH, so the body will activate buffer systems in order to neutralize this acidity. And it was proposed that the bone could serve as a reservoir of alkali substances. So when pH decreases, there is activation of a release of these substances from bone. And of course, to release these substances from bones, we need to activate bone resorption. And then by stimulating bone resorption, we of course release calcium that is excreted in the urine. So that's why we say that maybe animal proteins can leach calcium from bones. So this is the hypothesis. But I would say that more recently, this model has been challenged actually in many ways, and I will show you how in 5 points. So first of all, you have to know that sulfur amino acids are not only present in animal products, so they are also present in legumes and in grains. So it's not only animal products or animal proteins that should be blamed for this association with bone resorption. Secondly, buffer system. In this model, bone is a major buffer system, but it's not the major one. In the body, the major buffer systems are the kidneys and the lungs. And the kidneys are more reactive to changes in pH than the bone could be. So in this model, they didn't really take into account that kidneys could react to this metabolic acidosis by excreting more protons in the urine. So kidneys are more reactive, and it's probably the first buffer system that is activated when pH decreases. Alkali substances from bone. This was a hypothesis. We don't really know if bone releases a lot of these substances. These substances are, for instance, citrate, and we know that bone contains citrate, but not in high amounts. So this is not clear whether alkali substances are released from bone, and if they are released in sufficient amounts to impact the pH of blood. Also, what we learn with over the years is that the metabolic acidosis has an impact on the renal excretion of calcium. So it increases renal excretion of calcium. So it's a direct effect of the decrease of pH. It's not because of the increase of bone resorption. It's really an effect of the pH on the kidney function. So there's another mechanism that could explain the increased renal excretion of calcium. And lastly, proteins has a positive effect on calcium absorption. It's one of the nutrients that we have in our diet that promote calcium absorption. So by increasing intestinal calcium absorption, it is also possible that we increase the renal excretion of calcium. If we enter more calcium in our body, it is a possibility that we excrete more calcium. So all these points kind of I also show you that the negative effect of protein, especially animal proteins, on calcium homeostasis could be challenged. There are arguments that are against this link. Calcium recommendations now. So you probably know that here in Canada, we have North American guidelines. So it's the same recommendation as in the US. Here I showed only recommendations in healthy adults. So it's 1,000 milligrams in men and women. In women, it's until the age of 50. And from over 50 years old, it increases to 1,200 milligrams of calcium, whereas in men, it's over the age of 70 that the calcium recommendation increases to 1,200 milligrams. On the other side of my slide, you have the World Health Organization recommendations. So these recommendations are global, so they could be followed everywhere on Earth, but it's more designed for low to middle income countries. And you can see that they are very similar to the North American recommendation, except for the 1,200 milligram it's 1,300 milligrams for the World Health Organization recommendations. But in Europe, you could see that the recommendations are much lower. In the UK, it's only 700 milligrams of calcium that is recommended in the diet. So, and there are no sex difference and no distinction for age. I mean, over the age of 19 years old, it's the same recommendation. And the European Union, it's a bit higher, so 1,000 milligrams in younger individuals, and it decreases slightly to 950 milligrams in individual older than 19 years old, but again, no sex difference. So why such differences in calcium recommendations? It's a matter of endpoint. So for the UK, European Union, and also in other countries that I didn't mention, they use the calcium balance as the endpoint. What is the calcium balance? It's really the amount of calcium that we need to replace the calcium losses by the body. So, of course, we excrete calcium in urine, in the stool, in a little bit in the sweat. So we have to replace these losses in order to maintain blood calcium. So that's why these are the amounts required in these countries to replace calcium losses. But here in North America, and then also for the World Health Organization, it's not only to replace calcium losses, it's also to ensure that bone health is optimal. So that's why there is a sex difference. That's why there is an age difference in recommendations. So because the endpoint is different, it's not only to replace losses, but these recommendations are higher because they ensure that bone health would remain optimal. So that's why the calcium recommendations are vary from certain areas in the world. There is this question about long-term care residents. Are there specific recommendations for these residents? The answer is no. It's exactly the same recommendation, like depending on age and sex, so the North American guidelines. The only thing is that we have to be careful because often these residents may have poor appetite or low food intake or have other medical conditions that may need an adjustment in the recommendations. But for residents without any huge problems, the same recommendations apply. So I'm coming to the Canadian situation. So are Canadians getting enough calcium? So I will show you the data from the 2015, but actually I will show you a comparison of data between the 2004 and 2015 intake from the Canadian Health Measures Survey. So this is a national survey which includes the 10 provinces in Canada, and it's a sample that is representative of the Canadian population and it's made of Canadian age 1 year and older. Unfortunately, they did not collect nutrition intake data since 2015 because there are many cycles to this survey. So that's why I have to show you data that are almost 10 years old. But still, we could see trends. So in this paper, you could see here, so in the kind of reddish burgundy bars, you have the 2004 data. So it's calcium from food, milligrams per day. And the yellow bars, you have the 2015 calcium intake data. by age group and by sex. So here you have the children 1 to 8 years old, the first two bars, then the women, and then the men. The first thing you can see is that the yellow bars are lower than the burgundy bars, so meaning that our dietary calcium intake decreased between 2004 and 2015. But what I can say, yeah, it decreases and significantly with the stars in certain age groups. What it's not shown on this graph is that calcium intake comes primarily from dairy products. In Canada, it's the major source of calcium in our Canadian diet. But still, it could be concerning because when we add the calcium recommendation, you could see that in most cases, calcium intake are below recommendations. So the red dot line is the recommendation in children. So they're probably the group that does the better in terms of calcium intake, though it's slightly over the recommendation, but not that much. The blue line is the recommendation in healthy adults and also in young children. The 1200 milligrams of calcium is the recommendation in women, as I said, over the age of 50, and in men over the age of 70. And the 1300 milligrams of calcium is the recommendation in adolescents, so from 9 years old to 18 years old. So in most cases, the most recent dietary intake data are below these recommendations, meaning that we have in Canada a hard time to meet calcium requirements with diet. So let's speak about sustainable healthy diets, which is actually an emerging theme in nutrition. So health, planet, and calcium. Because you may have maybe encounter people who are eco-conscious, so they pay attention to what they eat, to the environmental weight of what they eat. So in 2019, the FAO and World Health Organization has released guiding principles regarding sustainable healthy diets. And in the same year, a group of experts has advertised what is called the planetary health diet. So the same year, we had two entities which have released recommendation regarding sustainable healthy diets. So what is the difference? What are the difference between these two diets? So first, the FAO and World Health Organization, as I said, it's guiding principles. So it's not a diet per se, it's really principles that are based on 4 domains. So health, of course, environment, economic, and social cultural. So they advocate diets that should promote health and well-being, that should have a low footprint for the environment, that should be respectful of local traditions, for instance, so that could be accessible, affordable, equitable. So they kind of promote that kind of diets, but it's not prescriptive. It's guiding principles, and these guiding principles do not have any nutritional challenges because it's not restrictive. It's really, you have to do your best to eat food that promote health, are economic, are social culturally acceptable, and are good for the environment. Whereas the planetary health diet is a healthy reference diet. So it's a prescriptive diet, meaning that you have grams per day to eat of certain foods that are primarily plant-based with limited animal-sourced foods. And of course, there are risks of shortfalls of essential nutrients. And calcium is one of these essential nutrients that are not enough, are not in adequate amount in this particular diet. And this diet includes two dimensions or two domains. It's really health and environment. So the prevention of chronic diseases is really one of the goals of this healthy reference diet, and also to reduce greenhouse emissions and other benefits for the environment. So this diet does not include the economic and social cultural domains that are present in the guiding principles of the other organizations. So what is this prescriptive or healthy reference diet, which is prescriptive, as I said, is, as you could see here, maybe small a little bit, but you have grams per day of macronutrient intake. So you have whole grains here, and then you have the prescription, so the number of grams per day you should eat. Dairy foods, so 250 grams per day, which is equivalent to about a cup of milk. Then you have the meat, the protein sources here, legumes, and the fats and sugars. So this diet is about 718 milligrams of calcium. For the experts who established this diet, they said that it's enough for our requirements. But I just want to remind you that the calcium recommendations here in North America are much higher than this amount of calcium. And it is based on evidence that these amounts are enough or are sufficient to ensure that bone health is optimized. So clearly, this planetary health diet does not contain sufficient calcium with respect to bone health. But it is good for the environment. So it has other advantages, but it clearly has a risk for nutritional deficiencies, not only for calcium, but also for other nutrients such as iron and zinc. But still, I follow a vegan diet. So I'm sure you may have patients or individuals that follow a vegan diet. Can I realistically get enough calcium from food alone? Yes, the answer is yes, but you need a thoughtful or a selection of food, and you have to think about it. So it's not simple. And here I show you a few examples of serving that contains 150 to 200 milligrams of calcium. So the plant-based beverages and the orange juice that are fortified with calcium, quarter cup of tofu or almonds, of course, 2 tablespoons of almond butter, because almond butter also contains calcium, 10 figs, which is a dry fruit that has a calcium in it, a cup of some greens, vegetables, a cup of white beans or other legumes, or 2 cups of broccoli. I just want to point out here that a cup of milk is 300 milligrams of calcium, and our recommendations, as I said, are between 1,000 or 1,200 milligrams, depending on the age and the sex. So, of course, you will need large amounts of these plant-based sources or plant-based foods to get the equivalent amount of calcium in a glass of milk. So, for instance, to reach calcium recommendations, you need a little bit more than 3 glasses of milk, but you would need much more, several cups of broccoli. So just to show you the differences in terms of servings. So is it achievable? Yes, with, as I said, a thoughtful food selection. But there are differences in because of the calcium content of this food is low, so you need large servings to get or to reach the calcium recommendation. And Osteoporosis Canada, where does it stand among all these recommendations? So Osteoporosis Canada kind of supports the North American recommendations of 1,000 milligrams in adults and 1,200 milligrams over the age of 70 in men and 50 in women, because of course the bone health is important. And what the osteoporosis kind of emphasizes is the food first approach. Ideally, to reach these amounts of calcium through foods, if possible. But sometimes I get the idea of getting calcium from food, but what if I have restrictive diets because of a medical condition, because I have a hard time swallowing foods, because I have allergies, so it may not be realistic to get this calcium from food, and there are other reasons. So some people may have aversions, so they might be personal preferences. It could be a low appetite, it could be cost or limited access, it could be also cultural dietary patterns that do not include these food sources of calcium. So in these cases, of course, a calcium supplement could be indicated, because what is important here is to reach calcium, is to achieve calcium requirements of our body. So if people cannot achieve that with food alone, but then maybe a calcium supplement could be another option for these people. And what are the risks of under-consuming calcium? Just a quick diagram here to show you how calcium is regulated in our body. So blood calcium is tightly regulated, actually, in a very narrow range. So the body does not allow calcium to move up and down a lot. So it maintains calcium in a very, as I said, narrow range through either regulation of the absorption, but also the exchanges with bone. So calcium goes into bone through formation, or calcium exits bone following bone resorption. And the body will also regulate calcium exchanges at the kidney level, controlling either reabsorption or excretion of calcium. If the intake of calcium is low, so if we have a low calcium intake, of course, this will be reflected in blood. So calcium in blood will get lower, but as I said, the body will rapidly react to this decrease in blood calcium by increasing bone resorption. Because it is really important to maintain calcium in blood, because calcium is involved in so many functions. So that's why it is rapidly normalized through activation of bone resorption, and also in kidneys by activating reabsorption of calcium. So if calcium intake are low, and if you measure markers of bone resorption, it is highly expected that you would see an increase in the bone resorption markers, either in blood or in urine. These markers are the C or the N telopeptides. What are telopeptides? It's actually breakdown products of collagen that are released with bone resorption, and could be measured in blood or in urine. They could be used as a proxy to indicate that there is something with bone resorption, that bone resorption is enhanced. And in people with low calcium intake, some studies have shown a correlation with an increase in these markers, either in blood or in urine. So I'm coming to the last part of my presentation, which is about the frequently asked questions about calcium. I will begin with the link between calcium and kidney stones. which is something that we usually heard a lot. This concern comes from the fact that kidney stones are made of either calcium and oxalate or calcium and phosphate. So 82% of stones are made at least of calcium. And the concern also comes from the results from this study, which is not a new study. It's an old study. The Women's Health Initiative study was conducted in the 90s, I guess, or early 2000s. It's in the US, of course. 18,000 postmenopausal women aged 50 years and older were randomized to receive calcium vitamin D over 7 years or placebo. And they observed a small increase in kidney stones in women who received the supplementation with calcium and vitamin D. However, stone formation was not a planned study outcome, meaning that the assessment of stone formation was not constant across centers who participate in this study. The composition of these stones was not analyzed. So are they made of calcium or not? We could not be sure. And calcium intake at baseline in these women were very high. So it was more than 1,100 milligrams, plus the supplementation of 1,000 milligrams, meaning that the overall or the total calcium intake amounted more than 2,000 milligrams per day, which is quite high. So all these elements have contributed to kind of establish perhaps a link between calcium and kidney stone. What is the current evidence right now? So we think that, it's not me, but it's the evidence that is in the literature so far. So dietary calcium intake that is normal protects. It has a protective effect on either the incidence, so new kidney stones, or recurrence of kidney stones when compared to people with low calcium intake. So it's better to have a normal calcium intake, which seems to be more protective than to restrict the amount of calcium in the diet. Why is that? Is because calcium binds to oxalate, as I said at the beginning of the webinar. Calcium and oxalate binds together. So calcium binds to oxalate in the gut, reducing the oxalate absorption and the oxalate excretion, meaning there are less oxalate in the body, in the kidneys, that could precipitate with the calcium and form kidney stones. So the link between dietary calcium and kidney stones seems to be not present. The link between supplemental calcium and kidney stones remains controversial so far and may depend on timing. Timing means that when supplement calcium is taken with meals, the risk of kidney stones seems to be lower, seems to be decreased or reduced, because the calcium from the supplements would bind the oxalate in food. But when the calcium in supplement is taken without meals, they observe a slight increase in the risk of kidney stone formation. So it really depends on the timing, especially with food intake. Another question that you may have had with calcium is the relationship between calcium and heart disease. So I've heard that too much calcium can build up in arteries. Is that dangerous? This concern comes from a study in 2008 from New Zealand, which reported that calcium supplements increase the risk of myocardial infarction in postmenopausal women. So it was not a study per se, it was actually a systematic review and meta-analysis of studies where there was a calcium supplementation arm in this study. So the mechanism that was proposed by the authors was that the ingestion of large amounts of calcium could promote the calcium deposition in blood vessels. So what is the current evidence? And I just want to draw your attention that there has been a new paper on this association that was published in 2023. So I will show you the reference later, but the current evidence is that there is no clear biological mechanism that supports a link between calcium and cardiovascular disease. The association was found only with supplements, but in the body, the tissues do not sense whether calcium comes from foods or supplements. So why is just calcium from supplements? This was not clear. And when we take calcium, even calcium supplement, there's only a small rise in blood calcium after supplementation. And this rise is too small to cause calcification. So from a mechanistical point of view, it was not consistent with the link. It was not supported by clear mechanism of action. And actually, there were a group of experts from the National Osteoporosis Foundation, which is now the Bone Health and Osteoporosis Foundation, and the American Society for Preventive Cardiology. And this group of experts has released a recommendation that calcium intake from food or supplement should not be greater than 2,000 milligrams or 2,500 milligrams of calcium on a daily basis. These numbers represent actually the upper levels of calcium. So when we have intake that exceeds these amounts, the risk of adverse effects increases. So it's really the upper level. And why we have 2,000 milligrams is for people older than 50 years old, and 2,500 milligrams is for people age low or age below 50 years old. So this recommendation was supported by Osteoporosis Canada, and this statement was also updated in 2024. As I said, following the release of this paper from Sim and collaborators published in 2023, which came to the same conclusion that there is no association between the intake of calcium and the risk of cardiovascular disease. So the bottom line is the benefits of adequate calcium intake, either from foods or supplements, clearly outweigh the risks. Then my last question is about milk. So should adults drink milk? And I will address this question with two perspectives. The first one is the nutritional perspective. So as I said, I'm a registered dietitian. So of course, milk is an excellent source of highly bioavailable calcium and of vitamin D, of course. It also provides a lot of bone supporting nutrients, including high quality protein. By high quality, I mean a protein that contains all essential amino acids. So in one food, you have all these amino acids that are necessary to, for instance, build muscles and build tissues in our body. But milk also contains other nutrients such as magnesium, phosphorus, and bioactive components. It's nutrient dense, so in one serving, you have a lot of nutrients, and it's convenient, of course. You don't have to eat a lot of foods, a lot of servings to get these nutrients. But you have also to take into consideration the individual. So some individuals may not like milk, and that's okay. They may have personal preferences, they may have values, they may choose not to drink milk for ethical reasons or for cultural preferences. So that's perfectly fine. So you have to take into consideration these factors. Also, the tolerance. Some people cannot tolerate dairy products, or they can tolerate dairy products but in small amounts. So it's a very individual factor that should be taken into consideration, and also the medical conditions that may affect dairy intake. So yeah, it's a good food from a nutritional perspective, but don't forget the individual behind all that. So in summary, I hope that you know more about the factors that affect calcium absorption, because the knowledge of these factors can help guide food choices and patient counseling. If well selected, of course, plant-based foods can help meet calcium needs. Many Canadians don't meet calcium requirements, so it is important to assess intake and address gaps if those gaps are present. Emphasize food first approach, but if it's not possible, use supplements if they are needed. There are no clear links between calcium intake and cardiovascular disease or kidney stones. And of course, the benefits of adequate calcium intake outweigh the potential risk. So this is my last slide. Thank you all for your attention. And if we have time, because I don't have the clock in front of me, but if we have time, I'm happy to take some questions.
That was great, Geneviève. Thank you so much. I think we've all learned a heck of a lot more about calcium than we knew before. I will ask you a couple of questions. I know we're at 2 o'clock, but I think it's great that we ask a few. So here's the first one. How does magnesium and calcium help with osteoporosis?
Yeah, there's always this relationship with magnesium and calcium. Magnesium, actually, there are a lot of magnesium. There's a lot of magnesium in bone. Bone is actually a reservoir of magnesium. So 50 to 60% of magnesium is found in bone, but it is actually surrounding the crystals of bone. So it is important for the bone composition. However, in the literature, the evidence is not very consistent regarding the benefits of taking magnesium supplements for optimizing bone health, especially because usually without any measure of magnesium status, we need to assess magnesium status. We need to know if the magnesium status is low. If it's low, then perhaps the supplements may have some advantages or to increase magnesium intake. But in normal individuals, with a normal magnesium status, to take magnesium doesn't seem to add any benefits for bone health. Yeah.
Okay. This is a very timely question that we get it frequently. What are the calcium requirements for transgender people?
Yeah, that's a great question, because in nutrition, it's really an emerging topic to assess and plan nutritional intervention in transgender individuals. Unfortunately, my answer will be a bit disappointing, but because we don't have any guidelines, it's so an emerging area that we don't have any guidelines. But what we know is that these individuals usually they display a higher rate of eating disorders, which could affect intake of essential nutrients. So they should be assessed for eating disorders and assessed for nutritional intake, just to make sure that they don't have any deficiency that we should address. But with regard to the impact of hormonal replacement therapy, so estrogen-based or testosterone-based. We don't have any data regarding whether these influences calcium requirements. So it's going to come up in the future, but for now we don't have any specific recommendation.
Okay, thank you.
But Kerry, I may
Yeah.
add, sorry if the person who asked the question is still in the audience. There is a recent paper that was released on nutritional assessment of transgender individuals in 2025. So if you can look up, it's really recent, and it has some information about the assessment of transgender women and men.
Okay, that's great news. Thank you, Geneviève. Just looking at the time, I'm going to ask one more question, and we'll leave it on a fun note. Somebody's asking a question about chocolate, and they want to know whether chocolate will interfere with calcium absorption.
That's a good one. Chocolate actually contains oxalates, so that's a good one. So probably if you eat chocolate with a calcium source, it might impact the calcium absorption in the food that contains calcium, because chocolate is not known to contain calcium. But if you eat chocolate if you eat chocolate with a glass of milk, yes, it may impair, but it's really an assumption here, because I don't have any science that backs this assumption, but it is a possibility because chocolate contains oxalates, so it might affect. But if you eat chocolate alone, then it might, because it's really the concomitant ingestion of foods that contain oxalate and phytate with calcium sources that may impact the absorption. But if you eat chocolate in the afternoon and then sources of calcium in the evening, then it would not impair calcium absorption of the foods eaten in the evening.
Okay, thank you very
But
much.
that's a fun one. Yeah.
I know. I had to leave things on chocolate.
Yeah.
Anyway, thank you so much, Geneviève. It was such an informative presentation. And we learned so much in the many facets of calcium. So thank you so much. And I also want to thank our partner, the Dairy Farmers of Canada. This was a great presentation about calcium. So the slide that's just come up now, it's talking about our nutrient calculator. If you want a tool to assess how much calcium and other nutrients you're getting in your diet, you can go to our website and find our nutrient calculator, or you can download it onto your smartphone. As well, our website has many other tools, including podcasts, quizzes, and a repository of past webinars. Here you're seeing advertised our next webinar on learning about bone building medications. And finally, I just want to say thank you to all of you for joining us today. I hope you join us again soon, and wishing you a great rest of your day. Thanks again.